everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. Welcome everyone again, and in this episode of the Surgical Ergonomics podcast, I am absolutely delighted to have as our guest Dr. Stephanie Pearson. She is a board-certified OB-GYN, fellow of the American College of Obstetricians and Gynecologists, an educator, a highly sought-after speaker, and advocate for physician well-being. After a career-ending injury, she founded PearsonRavitz, a national insurance brokerage dedicated to protecting physicians. Drawing from her own experience, Stephanie educates and empowers physicians on the importance of disability and life insurance. A very warm welcome this cold January day, Stephanie, and we're delighted, as I said, to have you on the podcast today.
I am honored to be here.
Stephanie, please tell our listeners a little bit about yourself, including sort of where you grew up and what your training background has been.
Sure. So I grew up in South Jersey in Cherry Hill. I went down south to Emory for college, came back home for med school. My diploma still says MCP Hahnemann. Younger folk will know it as Drexel University. And then I did my OBGYN residency at Pennsylvania Hospital. Then went on and joined one of my mentors at a community hospital right outside of Philadelphia.
I first met Dr. Pearson when we served on a panel together in the American Society of Pediatric Otolaryngology meeting in 2023. Shout out here to Dr. Julie Way, who introduced us. I have to let our listeners know that I was immediately impressed with not only your expertise relating to disability insurance, but also your story, which really is one of grit and resilience in the face of unexpected adversity pertaining to your career. And I'm hoping that you would be willing to share some of the details with our listeners, and especially how that kind of then led to your interest in surgical ergonomics.
Sure. So I really thought that I was going to be an OBGYN forever. Figured I would actually be like in my 80s operating, and a nurse would be like, "Hey, Dr. P, maybe it's time." And I would like throw my last stitch and have a massive MI at the table. Like that's how I saw myself going out. And life had different plans. About 10 years into practice, I was called to do a precipitous delivery, and she was actually one of my favorite patients. And I got in, and as I stated, it was precipitous. She came in complete, couldn't get an epidural, and there was a lot of commotion. I had nurses trying to help me get her in position so that everyone could be safe and have a healthy delivery. And I looked down, and the baby's heart rate was just tanking. And I knew I had to do something. And as I put a vacuum on the baby's head to help guide it out, I ended up actually getting kicked in the shoulder twice. The first kick came to my left brachial plexus. My arm went numb. I started to cry. I thought that I was doing myself a favor by kind of twisting about 45 degrees. And unfortunately, when I got the widest part of the baby's abdomen out, she actually lost the grip of her leg. Two of my nurses were injured, and the second kick kind of came across my shoulder, and I heard a pop. And I knew something was wrong. I was able to put the baby on mom's belly. I was called one of my partners to come finish with the placenta and putting mom's perineum back together. And little did I know, she tore my labrum. And my first orthopedist made a comment that professional baseball pitchers pitched with torn labrums, so I should be able to do my job. He used a little more colorful language. And
Wow.
I did what all type A docs do. I put my head down and I figured out how to compensate until I couldn't. And I developed a frozen shoulder. My next orthopedist said, don't worry, we'll operate. I'll have you back to work in 12 weeks. And that was almost 11 and a half years ago. I
Wow.
learned a lot the hard way about disability insurance and became really interested in ergonomics because poor ergonomics lead to a large amount of musculoskeletal disorders, which happens to be the number one reason that physicians leave practice. And so
Oh,
it was
wow.
natural arm of what I was doing and found important. And
Mm-hmm.
it meshed really well with what I'm trying to educate people on.
Mm-hmm. Wow, Stephanie, I have to say, I could picture you there from your description 11 and a half years ago as this happened. And it happened in the course of you doing your job. No one could have foreseen this coming. And it just goes to show that even though we don't traditionally think of surgeons and proceduralists as being one of those high risk professions for, disability and workers' compensation, etc., here we are, right? You were injured at work during a delivery. I can sense the pain as you described it. It seems like it's as fresh as it was 11 some
Oh,
years ago,
I can put myself right there.
right there. Yeah. Very brave of you to be open and share your journey. We'll be talking a little bit more about this as well. But I wanted to sort of point back to where you said, I did what we all do, right? And the thing is that we all do, I think we have to emphasize that that's the culture in medicine. We have to be dead to not be doing our job. You described how painful this was the first time, then you had a second kick. And only much after that did you call for help. And so I have to say this is one of the contributing factors to our epidemic of musculoskeletal injuries is that we don't take care of ourselves when we should. I've worked through multiple injuries myself. And so I just want people to kind of note that point where you said, I just did what we do. Why did this become our culture? Why and how?
I think it's been our culture for a long time. I mean, I've talked about what I think is like the tyranny of perfection that
Mm,
exists in medicine, right?
mm,
Which is decades and decades in the making, right? We're supposed to be stronger than, more resilient than, get
mm.
okay, be okay with no sleep and train like the military, right?
Yeah.
And somewhere along the way, it truly became the norm that, yeah, you kind of have to be dead not to show up to work. I mean, I remember, I was that pregnant girl. I had hyperemesis. I had an IV under my shirt and in between patients would get IV fluid, right? We would
Yeah.
never
Wow.
let our patients do that.
Right.
I'd write them a note to get out of work, right? Like,
Right.
you know, I had a kidney stone. I was in the hospital overnight. I got out of the bed and rounded, right? Like this is,
Oh my God.
I don't know if I ever shared those stories with you, but you know, these are
No, but
things
I'm glad
like,
you're doing it now. Yeah.
looking back, right? We're like, why would we do that to ourselves? And it's because that was the expectation.
Right. I think you're absolutely right. That has been our culture. And whether the profession selects people who have that sort of desire for perfection, unfortunately, whether that happens or not, then it's ingrained. You have some of that, then it's ingrained, it's celebrated.
Mhm.
I did this with this going on, etc. So I guess a key thing that I want to point out is that the power to change that culture is also with us, and that speaks to the work that you're doing and others are doing, and why and
Thank
the
you.
fact that we're talking about surgical ergonomics is a part of changing that culture. So thank you for your advocacy in that regard. By the way, listeners, all of us, we all need to have our personal physicians so that if we have an injury, like Stephanie just said, someone can give us a note because God knows we're not going to take ourselves out, right? And take the day off. I also want to come back to something else you mentioned towards the end of the last segment, which was in your work as a disability, well, as an insurance expert, but disability, work-related injuries, ergonomics and work-related injuries are the number one factor for physicians and proceduralists reaching disability, or did I misstate that?
So yes and no.
Okay.
So true work, like what gets documented as a work-related injury,
Hmm.
I think it's a misnomer
Okay.
because my injury got documented as a work-related injury. When we talk about musculoskeletal disorders being the number one reason for disability,
Hmm.
they don't get looked at necessarily as a work-related issue, even though it really is, right? It's
Right.
wear and tear over years. It's poor posture. It's, you know, poor instrument design
Yeah.
and, poor posturing at the OR table,
Hmm.
not poor posturing when we're seeing patients in clinic, right? Doesn't matter what kind of doctor you are, right? You end up sitting in a chair that often doesn't have a back and has wheels, and not all the tables rise and fall. So you put your bodies in these weird contorted positions.
Hmm.
And so it's over years, right, that these chronic issues happen. So really, by the time a doc leaves, it's more listed as an illness taking them out, not necessarily a work-related injury, even though at its root, it
Hmm.
really is.
I see. Based on what you just described, what is the number one sort of reason that physicians, proceduralists apply for disability?
So it's musculoskeletal disorders, mostly neck and low back, shoulders, a lot of hand and wrist issues. That's kind of the bulk. And I would say some of the worst cases that I've seen are spine issues.
Wow. And this kind of fits with the literature, right? So I want our listeners to spend a moment just pausing and thinking about this, right? You've spent years of your life training, and the injury, like the one Dr. Pearson experienced, can happen, but it's actually rarer.
Yes.
What's more common, and that's just what Dr. Pearson described, is this chronic repetitive strain injury that occurs in the OR or in all the other tasks that we do as physicians, not just in the OR, in the clinic, etc. And that is what ends up leading physicians, especially proceduralists, because there are more repetitive injuries there, ending up disabled. And I would imagine, Dr. Pearson, that this is pretty similar for other people who work in the OR, like nurses, like techs, like anesthesiologists. Do they also experience these work-related injuries as a cause of disability?
Yes.
Wow.
Yes.
Yeah.
It's, and again, I'm not telling you anything you don't know, but it's not just the physical ergonomics, it's the lighting, it's the mental load. I think that a lot of people, when they think of ergonomics,
Yeah.
they really just think physical, but
Hmm.
there are a lot of other pieces that kind of play into those injuries, illnesses, right? What have you, that encompasses so much of what we do.
Absolutely. Absolutely. And I know, like when I was thinking about ergonomics training and kind of looking at a curriculum for residents, et cetera, many years ago and education, I try to emphasize that there are many reasons to be having curricular and ergonomics training during our residency training programs or fellowship training programs. But one of them is that, at least my understanding of disability is that, you know, it's easier to say someone is disabled when there is an obvious cause and effect. Like you got kicked in the shoulder, your shoulder was dislocated, ligaments were torn. That is, A leads to B. And then if you can't work, then okay, you can't do your job, can't work as any job, et cetera, et cetera. We'll come to those questions. But On these repetitive strain injuries, that is usually what, physicians, nurses, techs, anesthesiologists, surgeons are experiencing. It's really hard to prove causality. And because it's occurred over so many years, and we know that these injuries and symptoms, work-related symptoms, start in residence. They don't suddenly appear, in your 40s and 50s. There might be an inciting or kind of the last straw that broke the camel's back kind of
Right.
situation, but really it's those years of things. So with that sort of thought, can you describe to us, what happens when someone is injured and how is it that it's determined whether someone is actually disabled, short and long term, if you can't prove this causality?
So you don't necessarily need to prove causality. You need to
Okay,
prove symptomatology and effect, right?
I see.
So if, and I say all of a sudden, but to your point, it's not all of a sudden,
Mhm,
but you finally reach a point where in
mhm,
your head, you're like, you know what? This may not be, I may not be the surgeon or the physician that I know I am or used to be, especially if you start to think that patient safety is
mhm,
involved,
mhm.
right? Then one, you have to have a treating physician, right? You don't get to say you're disabled,
I
right?
see.
You have to have a treating physician who is performing appropriate testing and actually says, right, Gita, I know that you do this surgery. You can't do this safely anymore, right? Or there's cognitive issue and you're not doing what you're supposed to do, right? And so you end up having a physician that has to report on a lot of things. And then you submit your claim to the insurance carrier. Now, there's a difference between employer benefits and private benefits. They are ruled by different governing agencies, they have different language, and you have to meet definitions independently, right? If you have both. Ultimately, it's your treating physician that gets to decide whether you're disabled or not. Now, the carriers have the opportunity to say, we're going to challenge this physician, and they make you have what's called an independent medical exam.
I
So it's
see.
a physician who does disability work, and they have a whole list of check boxes, and they're going to test your strength, your range of motion, what's your pain level like, what does your imaging look like. MRIs are hard to fight, right? If you have an MRI and you're showing a ton of degenerative disc disease and you're having numbness and tingling in your arms or your legs, or you're having
Yeah.
your gait has issues, they're more obvious. The some of the ones where, we might get some challenging is like carpal tunnel disease is one of those that sometimes they're like, well, if you wear a brace, right? Like what sort of accommodations could be
I
made
see. I see.
that would allow you to continue doing what you do? And like for me, I was not cleared to do obstetrics or operate. I was
Ah,
actually cleared to do office GYN as tolerated. The only
mm,
problem for me was that my contract said I needed to be able to do 100% of my job. So I got terminated the day my FMLA was up. And because my orthopedist put in my medical record that I'm a liability, I can't get malpractice insurance. Now, at the time, I hated him for writing that.
mhm, mhm.
Looking back, kind of circling back to our whole tyranny of perfection,
Yeah, yeah.
probably did me a favor because there's a good chance that I would have pushed myself and pushed myself. I could have made it worse. God forbid I missed something on an exam because I don't have the dexterity.
Right.
He probably did me a favor, but at the time I didn't think so.
Agreed, agreed, because it was such a huge sort of life-altering event, as you
Oh,
said,
yeah.
happened. But I appreciate what you're saying from kind of that lens 10 years later. For those of our listeners, I should point out that Dr. Pearson made another very important point that you need to have a treating physician, right? So we know that less from the literature, less than 5% of physicians report their injuries to anyone, right? We self-medicate and we keep pushing ourselves. And the problem is, well, one, it's, as you said, it makes things worse. But later on, when you get to the point where you really can't do your job anymore, there is no documentation of
Correct.
injuries, when it occurred, what treatment was given, what have you tried, etc. And so then you're fighting a different battle.
Correct.
So I'm going to make a plug for, I made a plug for all of us having a personal physician, but then also making an effort to report injuries when they happen. It doesn't necessarily have to be Awk Health. It's, you can go to your personal physician and start the process there. Am I correct, Stephanie?
Yes. And again, it's not necessarily an inciting injury, right? It's just years of wear and tear, but don't be remiss
Mm-hmm.
a positive review of systems, right? We get
Right.
asked, are you having any pain? And
Pain.
most of us lie and say no, right?
Yeah.
Because we're
Yeah.
worried
Yeah.
about our licensing. We're worried about somebody saying we can't do our jobs.
Our livelihoods are at stake, as you said.
So there's a fine line there.
Yeah.
But again, I think ultimately with a lot of the musculoskeletal disorders,
Mm-hmm.
there's imaging over the course of time. If you've said, hey, you know what, my shoulder does hurt, you may not get imaging from that visit, but a year later, you're making the same complaint. Now the doc may order some imaging. It's usually kind of following that imaging, and then it becomes, what have you done for it, right? So,
Exactly.
are you in physical therapy? Are you in occupational therapy? Like, what are you doing to try to make it better? It's just, you're better off if things are documented. But at the end of the day, for most of the musculoskeletal stuff, there's usually positive findings on imaging.
And if there has been, sometimes there are subtle changes, and if there's been progression on imaging, for
Mhm.
example, then that better supports your case
Right.
as symptoms progress. So, multiple reasons to at least look at reporting your symptoms early in a safe zone, getting the care, like if it's early enough, physical therapy may actually help delay progression.
I
And
often wonder what would have happened if I went to physical therapy right away. And I didn't.
so all excellent points, that you're making and, sharing with all of us kind of the lessons that you've learned. And I've learned many of these from you through our conversations over the years. Now, you mentioned earlier a little bit about how sort of employer-based disability versus carrier-based disability insurance is different. I was wondering if you could kind of delve into the nitty-gritty of this for our listeners, because they're going to be at all stages. I imagine this is a podcast is being listened to by trainees, surgical trainees. Maybe they're looking to purchase disability insurance. So we should also address, when is a good time. And then I'll just tack on the next question here too, I think, which is then what are some of Dr. Pearson's pearls when it comes to shopping for disability insurance? So I guess three parts. Let's start with part one. What's the difference between those two types of insurance?
So there are three main differences. One has to do with taxation. Most employer-based group disability policies are paid for by the hospital, and they're paid with pre-tax dollars. And so any benefit that you get is going to be considered taxable.
Hmm.
Whereas with a private policy, you're paying with post-tax dollars.
Correct.
So any benefit that you would get is going to come tax-free. And there's a big
Ah,
difference between money that's getting taxed and money that's not getting taxed, right? So that's number one.
absolutely. Yeah.
Number two has to do with ownership. So your employer policy, your employer owns the policy. So you change institutions, you change jobs, whatever they were giving you is staying with them. You don't get to take it with you. Now, everything I'm saying has caveats, just like in medicine,
Thank you.
but I'm painting with a wide brush. So, private policy, you own it, you keep it. It's what's called portable. So, it's going to go with you wherever you go. And kind of, I like to say it grows up with you, right? So, as you move around the country, you keep it with you. The biggest issue has to do with language. And it is infuriating that there's no standardization of language in insurance like there is in medicine. And so it's not surprising that people are confused. And it's, the mistakes I made, sheer ignorance. I just didn't know what I didn't know. And a lot of these group policies, they say their own occupation, but they're really not. It might be own occupation for 2 years, and then it switches to any occupation. The way they define own occupation is what's held to the national economy or the local labor market, not specific to what one employee does at one employer site. And I always use OBGYNs as my example.
Sure.
You put 100 OBGYNs up against a wall, we are not practicing the same medicine. We are not making money the same way. And so you don't want to be held up against your neighbor. You want to be held up against yourself. Also, with group benefits, a lot of times the way they define total disability is that you can't do your job and not be working. And I always say that definition stinks for most type A people. I used to actually say the old adage, I'd give my left arm to be home with my boys more, who were 4 and 6 when I got hurt. Turns out I gave my left arm to be home with my boys more. And after about 6 weeks, I was ready to kill everybody. You don't want to have to worry about losing any or all of your benefit because you're trying to figure out another profession, another job, if for no other reason to get out of the house. Whereas with private policies, and there are different phrases for own occupation,
Sure.
but what you want the definition to say for total disability is that you're considered totally disabled in the event that you cannot do your job. And I'll explain how they define that, regardless if you're gainfully employed in another occupation. So I'm still getting my disability payment because I'm not an OBGYN. Now, how the carriers define your own occupation actually matters at two different times in the life of the policy. When you purchase it, because we're all pushed into what's called an occupational class, which is the insurance company's internal dialogue of what's your risk of going out on claim, right? It's all actuarial based.
I see.
That affects cost. When you actually go to file a claim and say, okay, I can't do my job, the carriers will often pull both your calendar, your billing codes. How have you been making money? What procedures are you doing? And that dictates your own occupation at the time, which again makes sense because as our careers ascend, changes happen. And again, I'll use an OBGYN as an example. A lot of OBGYNs start their career doing everything. And 10, 15 years later, you have the people that have given up OB. You have people that have given up surgery. Had I given up surgery, them saying I couldn't do surgery wouldn't have actually affected anything. It's more, what are you doing just preceding a claim? So that's kind of the biggest differences. We also see in a lot of employer benefits that they're kind of sneaking in things that they're not covering or that they're limiting. And we don't have to get told. The biggest issue I have with group benefits, it's usually one line on your open enrollment packet and you check a box. You have
Pretty much,
no,
yes.
right? You
Yeah.
don't have the document. No one's going over the document with you. These documents can be dozens and dozens of pages long. And it's like a lie of omission. I
Mm,
didn't know in my group benefit, in fine print, it didn't cover work-related injuries. I got flatly denied and told I would have been better off.
Wow.
Yeah, I would have been better off if I fell off my bike. And it's a way for hospital systems to save money because workman's comp money and disability money come from two different places. So I had no idea. Now,
Actually, I didn't until you pointed it out
yeah,
that you'd think a hospital-based group policy would cover work-related injuries. You'd think.
you would like to think that, but hospitals are looking for ways to save cost, right?
Mm.
We've just recently, in the last 2 years, started seeing them put limitations on musculoskeletal diseases to 2 years. If you have a musculoskeletal disease disorder that takes you out, they're going to pay you for 2 years, and that's it. They don't have to tell us.
Very sobering.
They don't have to tell us what's in the document. You have to request it. And I don't know if you've had dealings with HR, but it is sometimes like pulling teeth. I help people, I give them the language to use, and I still get, this is what HR sent me. And I'm like, this isn't what I want. This is a summary. I need the whole document. And we don't know because nobody tells us. And so I like to think that if I knew that there was that hole, that I would have kept on top of my insurance better, which I didn't. The hugest mistakes I made was not keeping pace with my income. And so when I got hurt, I was actually underinsured. And I already told you I didn't get my group benefit. I had to
Right.
sue the state of Pennsylvania because they said that while an injury occurred, my frozen shoulder was idiopathic or my fault because I kept working while I was injured. I'm like, I was following my doctor's orders.
Orders, exactly.
You
Oh
know,
my.
there were a lot of pieces that kind of just didn't come together. And so I think it's really important for all physicians, get the whole policy, have somebody look at it with you. You don't have a choice. If they're employer paid, you're automatically enrolled. Now, sometimes hospital systems will have voluntary stuff, right? If you want it, you have to pay for it.
Mm-hmm.
There's a right time and place. I don't recommend it for everybody, but if
Mm-hmm.
you're somebody that has a complicated medical history, if you're somebody where, I know you're going to be hard to insure or there's going to be a bunch of stuff they're not going to cover, well, then I may tell you buy up, right? Because something's better than nothing. It's really important, I believe, that we at least have the education. It may not change what we can do, but at least then we have the knowledge to make informed decisions.
Absolutely. Now I'm sort of sitting here processing all the sort of pearls of knowledge that you've given and trying to distill for myself and our listeners. I think what I'm hearing is that most people are probably like me. You suddenly remember on November 15th that your deadline for open enrollment is coming up or whatever the date is, and you're desperately checking off those boxes. Personally, having worked almost 21 years, I have never asked to see the documentation of that employer policy. But then I know that I have a personal policy that I purchased at the end of my training, not soon enough because I experienced my first back injury as an intern, but at least I was covered for everything else. And I used an insurance broker. I was in Canada at the time and I used an insurance broker. And someone like you who has learned that language of the insurance broker and the things to look for, the pitfalls that physicians are likely to make, you've got that expertise. As unfortunate and as horrible as your injury and recovery and journey have been, you're using that knowledge, the mistakes, as you said, that you made to kind of alert the rest of us on the potential pitfalls of the two kinds of policies, the things you should look for. Briefly, if you could tell our listeners what actually an insurance broker does for you.
So I'm going to get a little nerdy. There is
By
some
all means, that's why I asked the question.
so there is a semantical difference between an insurance agent and an insurance broker, although the term
Okay.
kind of get used similarly.
Interchangeably. Yeah.
They're really not. An agent, by definition, works for a singular company, is incentivized to sell that company. A broker is like Switzerland. They are not supposed to be in bed with any particular carrier, not incentivized to sell one over another, has relationships with the big houses.
Mm-hmm.
In my opinion, what an insurance broker should do is properly educate, follow up, which was a big thing for me because my guy sold me my policy and I never really heard from him again. I want to make sure that we're touching our clients a couple times a year, and then service. And so for me, I care just as much about the back end as I do the front end, because when I got hurt, I felt completely isolated. When I called my broker, he was golfing in Florida and couldn't be bothered. If somebody calls me or us and thinks they have a claim, I end up speaking with every one of them. They get my cell phone number. I get their claims forms for them if I can, because some companies have weird rules. I explain what to expect, right? This is my journey. This is how I experienced it. Here's how some of our other clients have experienced it. And then I continually check in on them because I care. And so
And thank you
that's
for
what they
explaining the difference.
should be doing. You also asked previously when was the right time. So
Yes.
in my opinion, the right time is once you match. Med students can get disability insurance. However, I usually don't recommend it because they're not making money. And the insurance companies make it the most expensive because you haven't picked a specialty yet. And so they
Ah, that makes sense.
actually make that the most expensive. The only time that I recommend it is if somebody is thinking about family planning, because pregnancy is one of the top 5 or 6 reasons that people go out. So especially as an OBGYN, I want people's pregnancies covered. So that's really the one caveat. In between match and intern year, people actually have time to think about this stuff and let it gestate and make, in my opinion, the most informed decision.
Mhm.
If we miss them in between match and intern year, absolutely before you finish training, because there are resident and fellow discounts that don't
Mhm.
exist if you wait until you're an attending. Obviously, the younger the better. You pointed out you had your first injury as an intern. So I'm sure they're not covering part or all of your spine. So
Absolutely.
I always tell people, look, I wish I had a crystal ball. I'd be on an island getting a suntan, right? So we're not getting younger. We're usually not getting healthier. And so the younger you are, the cheaper it's going to be, hopefully more head to toe coverage. And so the short answer is before you graduate. The long answer is as soon as you can.
All absolutely what I should say platinum level advice for our
Thanks.
listeners. So, in keeping with that, I see that, this time that we had set aside for the podcast has just sort of marched on quickly. But I do want to follow up with two questions. One is should be a really easy one. How does one go about finding an insurance broker versus an insurance agent? And then two, I know you've given us a lot of pearls throughout this time, and you probably have a huge list of things that people should consider. But I want to know Dr. Pearson's 5 top tips as in terms of what things we need to pay attention to when shopping for disability insurance for any sort of healthcare worker doing surgeries, procedures, so nursing,
Everybody,
etc., all included. Yeah,
everybody.
everybody.
How do you find one? Um, Obviously, as I'm speaking with you, everyone can certainly look up
And
PearsonRavitz.
yep, and your
Um,
information will be in the show notes. So absolutely.
shameless plug. But again, there's word of mouth.
Okay.
There's the good old Google. I'm a big fan of referrals, right? Like talk to your friends and see what
Absolutely.
they're using and if they're happy. I think that you can kind of throw a stick and find one. You really, when you're speaking with them, number one, I always tell people trust your gut. Number two, you want to make sure that you're being shown multiple options. Anybody that comes to you with one is probably not doing you a favor. So,
Correct.
make sure that they're showing you multiple. You can always ask how they're getting paid. I will say, overall, for insurance, it's commission based.
Hmm.
All of our producers are salaried. I kind of wanted to take that ethical dilemma off the
Wow.
table.
That's unusual. Usually it is
It
commission
is
based.
very,
Yeah.
I know it is very
Yeah.
unusual.
Yeah.
Um, but I felt really passionately about it because I didn't want anyone questioning our ethics. And so, you can always ask that. You want to make sure that they're explaining definitions because, again, there's no standardization of language.
Language. Yeah.
Some companies, they can use the same phrases and define them differently. They can use different phrases and define them similarly. And sometimes things look the same and they're not. And so you want to make sure that you're actually being educated and not just, this is what you need. You want to make sure that you're comparing apples to apples. I've seen a lot of times where agents or brokers will just send somebody like chart, right?
Hmm.
Without the actual documents,
Hmm.
and they're facts in a vacuum. You can put in a chart whatever you kind of want. So I'm a little bit wary of those. And then going to the like, what should we be looking out for? So again, that it's specialty specific. And I say that instead of own occupation because there
Hmm.
are
Hmm.
differences. That's
Yep.
the single most important. The other thing is they really should be asking you some medical questions. Part of the reason I started the company was to manage realistic expectations. I don't
Right.
like surprises. And so if they're not asking you any questions, they're not really setting you up well. I want to be able to say to somebody, oh, so you had gestational diabetes? Look, I'm really sorry. They're not going to cover your future pregnancy. And so I think that they should be asking some questions. Now, the caveat to that is most people aren't physicians who are doing this.
Exactly. I was going to say, I don't remember being asked. I
You
just
know,
remember being given a form and I had to
right,
tick off
right.
all these things. Yeah.
I will also, under the, I was given a form and just checked
Yeah.
boxes.
Yeah.
There's no time limit on fraud. And there are a lot of times where people will check no when the answer is really yes, right? Or, I'll have to say to somebody, oh, I've learned the hard way to ask the following questions. And then things come up. But if something has happened, if you've seen a physician, if they've recommended testing, right, you have to fill it out because the worst thing that could happen is you are misrepresentative on an application. Years down the road, you think you have a claim. They do their due diligence and look back.
Hmm.
They can rescind the policy and not pay you, right? They'll give you back the money that you've put towards premiums, but that's not why you get the policy, right? We want the policy to be there when we need it.
So, good rule of thumb, don't lie to your physician and don't lie when
Yeah.
you're getting insurance quotes.
Because one of the problems that we do run into is like physicians who are prescribing their own medications, right? There has to be a paper trail. You need to have a doctor. I mean, I think we've both preempted this one enough. There's no doctor heal thyself. That doesn't work. You want to make sure that above all, you're being forthright. They have access to everything, your medical records,
Absolutely.
your
Yeah.
pharmaceutical records, your motor vehicle records. They all play in because they're looking at your morbidity risk.
Right. Thank you so much again, Dr. Pearson, for being on the podcast and for sharing your hard-earned wisdom with me as well as all of our listeners. So, thank you once again for all the advocacy work that you're doing as well.
Thank you. And you too. Hopefully we'll see a decrease in disabilities with good ergonomics.
God willing, we'll see.
Cool.
Please remember to subscribe to the podcast and follow us on social media, Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening.